Hello everyone and welcome back to my channel. So today's topic is liver tumor. This has got an overlap with surgery. So let's look at the pathological aspect of this topic. So liver tumors can be classified into non-neoplastic and neoplastic lesions. Under non-neoplastic you have focal nodular hyperplasia and nodular regenerative hyperplasia, out of which this FNH is an important entity. And talking about the neoplastic ones, you have the benign and the malignant version. Benign you have the hepatic adenoma, and under malignant, you have hepatocellular carcinoma, hepatoblastoma, and cholangiocarcinoma, out of which HCC is the most important topic. So let's start with each of these in detail now. So coming to this non-neoplastic mass lesion, we are going to only focus on focal nodular hyperplasia. There are important points to note here that it lacks a capsule. It has got a central stellate scar. So this is an important MCQ point. It has got a central stellate scar, and microscopically you're going to find fibrous septa radiating from the central scar, dividing the hepatic parenchyma into nodules. So if I can just show you this image, you can see here that this is the focal nodular hyperplasia. You have a central stellate scar. Rather, if I show you over here, this is a much better image where you can see this kind of a central scar which contains abnormally thick walled vessels and fibrous tissue which extends into the parenchyma of the liver. So you can see this is basically the central scar. So important MCQ point number 1, number 2 is that it is common in the females, and a prominent ductular reaction is often present, but the interlobular bile ducts are absent. Cytologic and architectural atypia is not present because it is non-neoplastic. And very important point, immunohistochemistry for glutamine synthase is very useful for diagnosis. So glutamine synthase is an enzyme normally present in the centrizonal hepatocytes, and therefore this is very useful for the diagnosis of FNH. So this is again an important MCQ point. And the third important point is that this glutamine synthetase is having a strong cytoplasmic positivity in a highly characteristic map-like pattern. So map-like pattern of glutamine synthetase is diagnostic of FNH. So this is again an important MCQ point. Now coming to the benign lesions, cavernous hemangioma doesn't require much explanation. Coming to the important point, which is the hepatocellular adenoma. This is basically a benign neoplasm that typically occurs in young women and associated with use of oral contraceptives and anabolic steroids. Again, a very important MCQ point, that whenever you see in the question young women on oral contraceptives or anabolic steroids, then the diagnosis is pointing towards hepatocellular adenoma. This is a benign neoplasm, not a malignant one. Now we will discuss the various pathogenesis. There are important points here to note. Number 1 is the hepatocyte nuclear factor 1 alpha, which is HNF1 alpha inactivated hepatocellular adenoma. तो यहाँ पर क्या होता है, यहाँ पर there is loss of function of the HNF1 alpha gene, and these mutations are responsible for autosomal dominant majority onset diabetes of the young, which is the type 3. So this has got an association with this has got a strong female predilection and is associated with the minimal risk of transformation to hepatocellular carcinoma. So this rather has a better prognosis because it has a very minimal risk of getting converted to hepatocellular carcinoma. Okay, you must remember these points. This can be asked in your MCQs. The next point is the inflammatory hepatocellular adenoma, and this is having activating mutation in GB130, which is a co-receptor for interleukin 6 that leads to activation of the JAK-STAT pathway, and this is basically the pathogenesis of this particular entity. And this is again associated with obesity and metabolic syndrome. Beta-catenin is present in only 10% of these entities, and these tumors have a high risk of malignant transformation. This is again a very important point, that yes, these tumors have a comparatively higher risk. So inflammatory adenoma have a comparatively higher risk, but the one which had the HNF1 alpha gene had a much lower risk of getting converted to malignancy. Now, beta-catenin activated hepatocellular adenoma, this is the third entity. This is defined by activating mutations in the beta-catenin gene or the CTNNB1 or the other components of the WNT pathway such as the APC. So here these genes are important. and these tumors have got a very high risk of getting converted to malignancy. So this is again a very important point. Now hepatocellular adenoma में क्या होता है? These are discrete masses, and what happens here is that it is composed of hepatocytes which are arranged in 1 to 2 cell thick plates. HNF1 alpha mutated tumors typically show prominent fat in the lesional hepatocytes, and by immunohistochemistry, the liver fatty acid binding protein or LFA-BP, a protein regulated by the HNF alpha, is absent. So because this gene was producing this protein, and now when this gene is mutated, there will be absent of liver fatty acid binding protein. This is again a very important point. This is the hepatocellular adenoma. You can see here that there are thin cords of hepatocytes with an arterial vascular supply, but there are no portal tract, and you can see this plate thickness is 1 to 2 cell thick. Okay, now what about the beta catenin mutated tumors? These tumors will show atypical cytologic or architectural features, and the areas showing overt transformation to hepatocellular carcinoma may be present due to beta catenin mutations or other mutations that activate the WNT signaling. Strong nuclear localization of the beta catenin is seen within at least a subset of the tumor cells. Inflammatory tumors will typically show sinusoidal dilatation and may have features mimicking the FNH, such as the fibrous septa and ductular reaction. Because of the hyperactive JAK-STAT pathway, these tumors overexpress the acute phase reactants like the C-reactive protein and the serum amyloid A. Now coming to the malignant tumors, in which we'll read first about the hepatoblastoma. Now blastoma means here the cells are either of the fetal or embryonal origin, means the hepatocytes are not mature over here. Okay, so this is the most common liver tumor of the early childhood. There is activation of the WNT signaling pathway, which is characteristic of hepatoblastoma, leading to nuclear beta catenin and increased expression of WNT target genes such as the glutamine synthetase in all the cases. This tumors is associated with FAP, familial adenomatous polyposis, and Beckwith-Widman syndrome. The types is that there is epithelial type and mixed epithelial and mesenchymal types. So what happens in the epithelial type is that it is composed of small polygonal fetal cells or small embryonal cells forming trabeculae, acini, tubules, or papillary structures. So if I just show you this image, you can see that this is an image of hepatoblastoma, and you can see that these cells, these tumor cells, they are arranged in sheets, and these cells, they are resembling the embryonal or the fetal hepatocytes. These are not the normal mature adult hepatocytes. They resemble the embryonal hepatocytes, and therefore the tumor is hepatoblastoma. Now coming to the entity which is the most important, hepatocellular carcinoma. This is more pronounced in the males. The setting of a chronic liver disease with cirrhosis, 15 to 20% can arise in non-cirrhotic livers as well. There are underlying diseases like hepatitis, metabolic diseases, etc. And of course, this aflatoxin produced by aspergillus is important in the pathogenesis. So this is like an important MCQ question. You can see this is the hepatocellular carcinoma. These are the malignant hepatocytes growing in distorted versions of normal architecture, and they have a thickened hepatocyte trabeculae. There is an unusual histologic subtype that often occurs in the adolescents, and that is in the absence of pre-existing liver disease, and that is fibrolamellar HCC. This is a variant which occurs in the absence of any pre-existing liver disease, and this is strongly associated with the fusion genes that leads to aberrant activity of the protein kinase A, which is an enzyme that participates in signaling pathway by CAMP. So this is associated with this. So these two are connected. Okay. Now, in the non-cirrhotic liver, HCC can arise in hepatocellular adenoma, especially those with beta-catenin activating mutation. I've already mentioned this point before. In the chronic liver disease, the earliest morphological alterations that appear to correlate with the presence of at-risk hepatocytes are called the large cell and the small cell change. So large cell change means that the hepatocytes are larger than the normal, and they have large multiple pleomorphic nuclei without an increase in the NC ratio. So here you can see this image shows you the large cell change, that these hepatocytes have become large and the nuclei is also very pleomorphic, right? You can see that the cells have become so large and the nuclei are also pleomorphic. They also having prominent nucleoli, and this is the small cell change where you can see that the cells are kind of having a high NC ratio, and they are separated by these thickened plates, right? They are separated by these thickened plates, and the cells have become so smaller compared to this normal appearing hepatocytes. This is basically the normal area. Okay, these are the normal hepatocytes. The normal hepatocytes look like this, and you can compare them with this. This is the area where the small cell change has occurred, and this is the normal hepatocytes. Okay, more ominous are nodular lesions in cirrhotic liver, referred to as the dysplastic nodules, which are often associated with the small cell change. Now, tumors larger than 2 cm are more likely to be associated with vascular invasion and intrahepatic metastasis. Invasion of veins with extension into the portal vein, inferior vena cava, and even the right side of the heart may occur. Now, this was the fibrolamellar carcinoma that I was talking about, where you see the protein kinase A was getting activated, and these are the nests and cords of malignant appearing hepatocytes separated by dense bundles of collagen. So you can see that there is so many collagenous bundles, and in between you have these nests of malignant cells, malignant hepatocytes, and they are kind of having oncocytic appearance. Oncocytic appearance means the cells have turned into kind of a round, a circular shape with eccentric nuclei. And this is what you see in case of the fibrolamellar variant. There can be question based on the fibrolamellar variant, so please be careful. This entity arises in conditions where there is no pre-existing liver disease. The distinctive fibrolamellar variant shows a characteristic triad of features. Very, very important MCQ point. Number one, large polygonal cells with granular or oncocytic cytoplasm due to abundant mitochondria. Number two, vesicular nuclei with prominent nucleolus. And number three, parallel lamellae with dense collagen bundles. So all these three has to be present, and these form the triad of features pointing towards this fibrolamellar variant. Now, elevated levels of a serum alpha fetoprotein is a frequent finding in advanced disease, but it is not sensitive as a screening test for early tumors, and it is not associated with the fibrolamellar variant. So, very important, alpha fetoprotein is not associated with the fibrolamellar variant. This is again an important MCQ point. So I hope you learned something from me today. I will come up very soon with the next episode. Till then, take care, keep studying, and thank you for watching.